Hi, my name is Ali Yılmaz. I'm a pediatric radiologist at McMaster Children's Hospital, and I'm going to talk about imaging of acute appendicitis. Before I start, I need to tell you that this is a long lecture. It's a 2-hour lecture almost, and it's made for YouTube so that you can pause and continue later. Here you can see the outline of my talk. I will start with the diagnostic algorithm. The focus will be on ultrasound, but I will also mention X-ray, CT, and MRI, and at the end I will mention the differential diagnoses. There will be a lot of repetition. I will show hundreds of cases. Uh, the repetition enhances the teaching. That's the idea. So if you look at the common pediatric abdominal emergencies, appendicitis is one of the very common ones in the ER admissions. It is still the most common abdominal emergency that goes to surgery. And under 2 years, it is so rare. Most likely you will never see a case or only a few cases in your life under 2 years. But it can be seen as a newborn even. But we start to see it after 2 years and more common after 6 years. The term appendicitis was first used by Dr. Fitz. This guy, he was an pathological anatomy professor in Harvard University, and he published a 40-page book, as you can see the cover here, in 1886, more than 130 years ago. So in the conclusion of the 40-page book, it's available online, by the way, you can find it. There are three statements. The first one is the vital importance of early recognition of perforating appendicitis is unmistakable. Agreed. Its diagnosis in most cases is comparatively easy. Agreed, but we are seeing challenging cases as well. Its eventual treatment by laparotomy is generally indispensable. Agreed, not just laparotomy, but also laparoscopy and nowadays antibiotics. As a general approach, this is what I understand. If there is a patient with a clinical suspicion of acute appendicitis, the patient can have a low clinical suspicion, moderate clinical suspicion, or high clinical suspicion. So when there is low clinical suspicion, the patient is discharged, no imaging necessary. When there is a high clinical suspicion, patient goes to surgery. Imaging is not necessary but may help to confirm the diagnosis or the complications of appendicitis. But imaging is particularly important in this group with moderate clinical suspicion. In this group, we need imaging and we should start with an ultrasound. That's the general approach. But if we look at in detail, based on ACR appropriateness criteria, there are 5 variants that are very helpful. The first variant is a child with suspected acute appendicitis, low clinical risk, and we are doing the initial imaging. As you can see, none of the modalities is appropriate. So if there is low clinical risk, don't do imaging. Variant 2, a child with suspected acute appendicitis with intermediate clinical risk, and the initial imaging should be ultrasound. Ultrasound is the appropriate initial imaging study. Don't start with a CT or MRI. The third variant is a child with suspected acute appendicitis, high clinical risk. So the patient may directly go to surgery, but imaging may be appropriate, either ultrasound, CT, or MRI. You can confirm the diagnosis or you can look for the complications of appendicitis. The first variant is a child with suspected acute appendicitis. equivocal or non-diagnostic first ultrasound, right lower quadrant ultrasound, and we are doing the next imaging study. This is not the first one. Then, if the first one is not diagnostic, then we need to do a CT or MRI. As a rule of thumb, CT is always with IV contrast, and MRI can be done without IV contrast, and it's usually enough. And we usually don't need contrast injection in MRI, but it's also appropriate with contrast injection. The important thing is we are not giving oral contrast, we are not giving rectal contrast in children. And the last variant, fifth variant, is a suspected acute appendicitis with clinical suspicion or initial imaging suggestive of complication. So you most likely there is an abscess or bowel obstruction, and if you're doing the next imaging study, this should be a CT with IV contrast. You can also do an MRI, but ultrasound will most likely be not appropriate or useful. Many approaches are available, and this is the one we are using at our hospital. We developed this as a quality improvement project. We implemented the white blood count cells to the algorithm, and based on the ultrasound findings and white blood count cells and clinical findings, we do a risk stratification, and the general approach is based on this risk stratification, as you can see here. In the pathology of appendicitis, the most common mechanism is obstruction of the lumen from various etiologic factors that lead to increased intraluminal pressure. When the pressure increases, it produces ischemic injury by compressing the blood vessels and then causes bacterial proliferation and then acute appendicitis. Macroscopically, if you see a purulent discharge over the appendix, if you see pus over the appendix, and it's easy to confirm the diagnosis in a distended appendix. Microscopically, there is neutrophilic infiltration of the wall of the appendix. This image I got from Wikipedia. This is the lumen of the appendix. This is the wall of the appendix. And these tiny blue dots are neutrophils infiltrating the wall. And we can see the infiltration of the entire wall. The diagnostic criteria is to see the neutrophils in the muscularis properia. If you see neutrophils in the mucosa, you cannot confirm the diagnosis. You need to see the infiltration in the muscularis properia. This is the key for the diagnosis. This is what the pathologists always look for. Then, when the appendicitis progresses, we will see congestion and edema. Then, in the advanced stages, the mucosa is sloughed off, the wall becomes necrotic, blood vessels may be thrombosed, and there may be neutrophilic abscesses in the wall. The sonographic anatomy of the appendix is similar to other intestine. Here you can see the appendix, a normal appendix in transverse plane with correlation of histopathology that I got the image from Paulina's histology atlas. And here you can see the mucosa, submucosa, and muscularis externa, which is muscularis properia, and there comes this outer serosa layer. On the ultrasound correlation, we can see the lumen and the mucosal interface as an echogenic structure. Then comes the first hypoechoic layer, which is called lamina propria and mucosa, some part of the mucosa as well. And then comes the echogenic layer, which is submucosa. Then the second hypoechoic layer, muscularis propria, because it's muscle. And then serosa is not well seen on the ultrasound. The inner hypoechoic layer, the lamina propria, is filled with germinal centers and lymphatic nodules. And there is also abundant lymphoid tissue in the submucosal layer around it, but there are also vessels here. So on the Doppler, we see the vessels usually in this part of the wall. And this lamina propria is important because in lymphoid hyperplasia, this is the layer which thickens. So what is lymphoid? Lymphoid hyperplasia is common in children. It's a physiologic response to infections. Usually after a viral infection or a bacterial infection, there is proliferation of the lymphatics as a defense mechanism. Also everywhere in the intestine, but also in the appendix. This is a very nice paper showing this with the correlation of ultrasound and histopathology. As you can see here, there is this normal appendix with the lamina propria layer. This layer consists of lymphatic centers and abundant lymphoid tissue, and it is usually measured under 0.8 millimeter. But when there is lymphoid hyperplasia, then there is proliferation of the lymphatic centers and lymphatic tissue, so that we can see it on the ultrasound as thickening of the inner hypoechoic layer over 0.8 millimeter. This is reversible and this is a physiologic response. However, it may cause obstruction of the appendiceal lumen and can be an etiologic factor of appendicitis. But based on research, it's not that common. The association is not that common. In this paper, Chang et al. Reviewed more than 3,000 appendices. Most of them are children, and the association of lymphoid hyperplasia and appendicitis is very rare. It's usually the fecalids causing the appendicitis. So the lymphoid hyperplasia should not be overcalled as appendicitis on the ultrasound. So how do they look on the ultrasound? So when there is fecalid, there is clear obstruction, there is distension of the lumen, there is fluid in the lumen. But when there is lymphoid hyperplasia, there is thickening of the inner wall of the appendix, which is the lamina propria, but then there is also inflammation. So this is also appendicitis, but the underlying etiology is most likely lymphoid hyperplasia. In this one is fecalid. So I reviewed hundreds of ultrasound cases before I created this presentation, and what I found is basically 9 different types of appendix. So this could be the most important slide of my presentation. I'm not saying it's covering 100%, there may be variations, but this is covering most of the presentations in daily life. So what are these? So I categorize as normal with lymphoid hyperplasia and appendicitis. Lymphoid hyperplasia is also normal. This is not appendicitis. So it is just a variation of the normal, but this is a different category because it is commonly overcalled. That's why we should recognize it. And this group is appendicitis. This is based on the diameter of the appendix and the content, and if there is presence of lamina propria or not. So we have 9 categories. It's a normal appendix, collapsed lumen under 6 millimeters, normal appendix, not collapsed, it's filled with content, with fluid. There's gas, there is feces, and still under 6 millimeters. 6 millimeters is usually the cutoff. And normal appendix over 6 millimeters. It's not always the case. When it's filled with content or fecalid, then it may be distended, but still normal, not inflamed. When there is lymphoid hyperplasia, we see thickening of the lamina propria, which is the inner hypoechoic layer. Lamina propria thickens, but the appendix is still under 6 millimeters. Then the appendix can be larger, between 6 and 8, and then the appendix can be over 8 millimeters. This is rare. This is more common. These are more common. And then when there is appendicitis, the diameter of the appendix is always over 6 millimeter. I haven't seen a single case under 6 millimeter and turns out to be appendicitis. So size is important. When it's under 6, you can reliably call it normal or a normal with lymphoid hyperplasia. But when it's over 6 millimeter, as you can see here, it doesn't mean that it's appendicitis. It can still be normal. So here, this is one of the most common. The appendix is filled with content over 6 millimeter, inflamed. And the second pattern is still over 6, but there is a fecality associated. And then there is lymphoid hyperplasia. The appendix is now over 6 millimeter, but there is no fluid in the lumen. There is no fecality. The underlying pathology is most likely lymphoid hyperplasia, but there are secondary signs here. In this one, there are no secondary signs in this group. In this group, there are usually there are secondary signs. In this group, there are no secondary signs. Okay. When it comes to the technique of ultrasound, the most important piece is compression. The compression ultrasound is recommended for the first time by this paper in 1986. Until that time, they were still using ultrasound for the diagnosis of appendicitis, but they were not doing graded compression. So in this paper, they are recommending compression by the probe by using two hands over the region of the appendix to displace the bowel loops and the bowel gas. But and they even showed this by a CT study, the effects of compression, how it displaces the bowel loops. So this is the most important piece, because in most cases that we cannot see the appendix, if you do enough compression, you can see if you can find the appendix. It's not always possible. And this is different than the compression of the appendix. This is based on the technique. So on the normal appendix can be seen in the right lower quadrant as a hypoechoic tubular structure arising from the posterolateral aspect of the cecum, approximately 2 cm below the ileocecal junction, most commonly anterior to the psoas muscle and the iliac vessels on the longitudinal view, and also here on the transverse view. It is slightly compressible, and there are no secondary signs around the appendix. The surrounding soft tissues are normal. There may, however, be a little simple free fluid in males and females normally. This is a list of the sonographic features that we need to look for while assessing for appendicitis. We need to check for the diameter of the appendix. It's normally up to 6 millimeter, to see if there is echogenic fat, compressibility of the appendix, wall thickness and integrity. It's normally under 3 millimeter. If there is target sign or not. We need to look for appendicolite. We need to check the vascularity. We need to see if there is increased periportal echoes in the liver, and also if there is fluid collection. So I will show you some examples. I will start with a normal appendix. As you can see here, this is a normal appendix with a diameter measuring up to 3.8 millimeters. It is not really compressible, but compression is subjective and it really depends on the technique. We assess the compression on the transverse plane. On the longitudinal, it's more difficult. And on the transverse plane, we expect to see around 20-25% of compression in a normal appendix. It's never 100% compression as a vein. It's not a vein. You cannot fully compress an appendix. And vascularity, there is normally some vascularity in the wall depending on your technique. If you're using a sensitive technique with SMI, for example, you can see some vascularity. It doesn't mean that there is hyperemia. And if you see multiple punctate discrete flows in the wall, as in this case, it's normal. And this is the color flow, it's normal. The surrounding soft tissues are normal. There's some echogenicity around it, but you shouldn't be overcalling it as echogenic fat. And there is some gas or fecaloid material in the appendix. So this is a completely normal appendix under 6 millimeter. This is falling into the group in our 9 categories. This is in keeping with this normal appendix under 6 millimeter filled with content. Another example, this is an appendix measuring up to 7 millimeter. It's the standard, it's over 6 millimeters, and there is some gas in it. Gas is actually a sign of a normal appendix because there is gas extending from cecum into the appendix, so there is no obstruction. However, when in the advanced cases, when there is necrosis in the wall, we can see gas as well. So gas means a normal appendix or a very advanced necrotizing appendicitis. And some vascularity in the wall, and we see some flow coding in the lumen. These are artifactual, obviously. And we can see mild compression. This is normal compression that we expect from a normal appendix. And as you can see here, there is some increased echogenicity around the appendix, but this is normal increased echogenicity. We shouldn't be overcalling it. It's very uniform and it's not pronounced around the appendix. It's even distant to the appendix. We see this echogenicity because the surrounding fatty tissues can appear hyperechoic. Normal fatty tissues can appear hyperechoic as well. So this is falling into a normal appendix over 6 millimeter and filled with content. Compressibility here, in this case, we see a normal compression of an appendix. It's very subjective and dependent on where you compress the appendix. Some part of the appendix may be more compressible than the other parts, and you can tell if the compression is adequate by looking at the soft tissues. Here, for example, with the compressed image, there is decreased thickness of the normal soft tissues between the skin and the appendix, so that there is enough compression, but still the lumen is not compressed. And here there is decreased soft tissues and the compression is adequate, and this is a normal appendix. Just to show you, it's not a reliable finding. Sometimes there is appendicitis and you can compress the appendix. Sometimes it's a normal appendix and you cannot compress it. Here is another normal appendix. You can see it. This is where the cecum is located. It's extending from the cecum. There's some gas with dirty acoustic shadow. And here is the lumen of the appendix. It's measuring up to 6.7 millimeters. So it is over normal limits. And you cannot see it nicely. This is usually the case when the appendix is normal. It's harder to see it. When there's appendicitis, it is distended, it is inflamed, so it is easier to visualize. And this appendix is actually falling into the same group. It's a normal appendix over 6 millimeter and filled with content. Another example of a normal appendix, here it's actually diving deep to the iliac vessels. filled with echogenic content. Here is the cecum arising from the cecum. This is the base, this is the tip, so we can see it all the way. And here is the measurement, 5.5, so it's under 6. This is a normal appendix. One of the important things to measure the caliber of the appendix is the landmarks. So we measure the appendix from the muscularis propria layer to muscularis propria, from the outer hypoechoic layer to outer hypoechoic layer, and our landmarks is the outer part of this layer. So we shouldn't be under measuring or over measuring it. So this goes to a normal appendix under 6 millimeter and filled with content. Another example of a normal appendix, here is the appendix. There is not content, but maybe some gas in the appendix. There's where the cecum is located, blind ending tip, and this is the measurement. So there are two hypoechoic layers in the appendix. One is the laminopropria, the other one is the muscularis propria. So we need to measure from the outer part of the muscularis propria to the outer part of the muscularis propria on the other side. So this is a normal measurement. Most likely this one is corresponding to serosa, but we are not including that. The measurements are usually higher on the CT and MRI compared to ultrasound, and usually in pathology they also measure, and they are usually lower than what we measure, obviously because it is not the standard anymore after surgery. And in this case, there is a difference because there is thickening of the laminopropria, which is the inner hypoechoic layer. So it is 0.8. So it's usually under 0.8 millimeter. And so this is not a completely normal appendix. So there is lymphoid hyperplasia in this case. And this is falling into the category of the first one. This is a normal case, not appendicitis, with lymphoid hyperplasia measuring under 6 millimeter. Here is another example of a normal appendix. It's a very superficial appendix just lying beneath the anterior abdominal wall. It is compressible. It measures 6.6 millimeter without compression. After compression goes down to 4.7 millimeter. Some increased echogenicity around it, posterior to it, but this is most likely due to posterior acoustic enhancement. As you can see, some increased echogenicity behind the appendix. This should not be overcalled as echogenic fat or creeping fat. The vascularity is within normal limits. So the striking finding is this layer, this internal hypoechoic layer, which is laminopropria, is thickened. It's over 0.8 millimeters. So there is lymphoid hyperplasia. And the clinical presentation is a 12-year-old with 1 month history of abdominal pain. It's intermittent. So clinical presentation is not acute appendicitis. There is some free fluid, simple. It's not a complex collection. It's little. But by itself, simple free fluid, small amount doesn't mean much. It's a secondary sign of appendicitis, but we see it very commonly in normal individuals or individuals with lymphoid hyperplasia. So how do I know that? If this is lymphoid hyperplasia, it should be reversible. Yes, it was reversible. I know it because we did follow up this patient, and on the 6th month follow-up, the appendix appears more normal. Here the lumen is measuring 4.7 millimeter now. There is no thickening of the laminar propria anymore, so there is no lymphoid hyperplasia. So this appendix is falling into this category, initially an appendix with lymphoid hyperplasia measuring between 6 and 8. On the follow-up, it goes down to 7.4 millimeter, and there is no lymphoid hyperplasia anymore, as you can see here. Here is another case with normal appendix, but overcalled as appendicitis. 6-year-old male found to have pyelonephritis and treated with 2-week course of antibiotics. On the ultrasound, the appendix looks very distended here, measuring 8.6 millimeter, way over our cutoff of 6 millimeter. But the striking finding is the wall. The wall is thickened. The laminoproperia part, the inner hypoechoic layer is thickened. The outer hypoechoic layer, which is the muscularis propria, is not, as you can see here. So we are measuring the appendix from outer to outer layers of the muscularis propria, it's thick, and there is hyperemia. This is a little bit over normal. And then it is not very compressible. It is going from 7.8 to 7.5 millimeters, so it's not compressible, it's thickened, there is hyperemia, and the radiologist called it appendicitis. But this patient didn't have a clinical presentation of appendicitis, and then treated. After the treatment, we repeated the ultrasound. And as you can see here, the appendix is normalized. There is no lymphoid hyperplasia anymore. The lumen is actually filled with fluid. It measures 5.6 now, and there is no hyperemia anymore. And the compression is better. So it goes from 6.5 to 5.4 millimeters. So it normalized. So it was a case with lymphoid hyperplasia, most likely because of pyelonephritis, and because it was reversible, it became normal after the treatment. So initially it was under this category, a case with lymphoid hyperplasia over 6 millimeters. Then after the treatment comes down to a normal case under 6 millimeters filled with content. Other example of a normal appendix with a thickened laminoproperia is just over 0.8 millimeter. The diameter is 6.1 millimeter. The measurement is from the outer aspect of the outer layer of the appendix, outer hypoechoic layer of the appendix. So this is the correct measurement because the outer layer, which is the muscularis propria, is going all the way here. So the measurements are going up to 6.3 as well. It is a compressible appendix. There is no hyperemia, there is color box here. So this is actually a normal appendix, but this was overcalled as appendicitis, and there are no secondary signs. There is no fluid, there is no increased echogenicity. Some increased echogenicity, but it is uniform. It's everywhere. It appears a little bit echogenic, and this should not be overcalled as echogenic fat around it. So this is falling into the category of lymphoid hyperplasia with an appendix measuring between 6 and 8 millimeters. Another normal appendix with a markedly thickened laminoproperia. So thickened laminoproperia, this is lymphoid hyperplasia, but is there appendicitis as well? So let's check. There is some hyperemia. So hyperemia, we are seeing this hyperemia in patients with lymphoid hyperplasia. And there are also multiple lymph nodes. So this patient, I know that it's 100% it is lymphoid hyperplasia because this is a 10-month-old with biliary atresia post-Kasai. And there is no clinical picture of an appendicitis. And this is the ultrasound. The appendix is measuring up to 4.5 millimeters only. And this has not progressed into appendicitis. So in lymphoid hyperplasia, we expect to see some hyperemia. There are no secondary signs. This is how we can differentiate it from appendicitis, but it's also tricky because there are lymph nodes. Lymph nodes are secondary signs. Hyperemia can be a secondary sign, but we can see it. Increased echogenicity. So in this case, there is some increased echogenicity, but it's very diffuse, most likely related to the underlying pathology or just technical. It is uniform. It's not more pronounced around the appendix. So this should not be overcalled. So this is falling into the first category of lymphoid hyperplasia, measuring under 6 millimeters. The size of the appendix, by the way, does not change by age. That's why when in the newborn there is a comparatively very large appendix because it still measures around 5-6 millimeters, but it doesn't change by age. Here is another normal appendix, and this was questioned as recurrent appendicitis because the patient was coming with abdominal pain, intermittent abdominal pain. We are doing an ultrasound, and in some reports it was called as appendicitis. So here is the example. January, the patient has a distended appendix measuring 7 millimeters, and there is thickening of the inner hypoechoic layer, which is lamina propria, and questionable increased echogenicity around the appendix. This is most likely technical. This is not real because the patient actually the symptoms resolved, and we did a follow-up. On the follow-up, we saw similar findings, even more like further thickening of the inner layer. So there is still some lymphoid hyperplasia. The vascularity is more prominent, but still within normal limits. And there is no appendicolit or there is no fluid collection, and the symptoms resolve. And in November, there is now not much lymphoid hyperplasia. The lamina propria measures thinner than the previous ultrasounds. The diameter is now 6 millimeters, so normalized. So this was not a recurrent appendicitis, but this was just recurrent lymphoid hyperplasia. I believe most of the cases that were questioned as recurrent appendicitis is this group of patients. And this is in our chart, it's falling into this category. An appendix with lymphoid hyperplasia measuring between 6 to 8, and on the follow-up, it's normalized, measuring under 6 millimeter and filled with content now. Another normal appendix, but definitely thickened lamina propria, so there is lymphoid hyperplasia, there is no hyperemia, the vascularity is within normal limits, psoas muscle normal, the surrounding soft tissues are normal. Some trivial, simple free fluids can be seen in normal patients or patients with lymphoid hyperplasia, and it's not compressible. So compression is not a reliable finding here. Here, there is some compression. Depending on the part of the appendix, the compression can change also depending on the sonographer. The, if the sonographer exerts a significant pressure, you can see the compression. If not, you may not. So this patient falls into the first category with lymphoid hyperplasia measuring under 6 millimeters. Another one, which is overcalled as appendicitis, because there's some hyperemia and there is thickening of the lamina propria. So when there is thickening of the lamina propria, the inner hypoechoic layer, the appendix becomes more visible as if it is inflamed. And there is some hyperemia as well because we may see some hyperemia in lymphoid hyperplasia. And in this case, it was called as increased echogenicity around the appendix. But if you look at it, this is very uniform. It's involving the entire soft tissues, not more prominent around the appendix. And there are some lymph nodes, but they are very small. These lymph nodes are very small, and in children, up to 8 millimeter in short axis is normal. So this was a normal appendix, but overcalled as appendicitis. There are no because there is lymphoid hyperplasia, and secondary signs are not available other than hyperemia. But this is a hard case, but the measurements help in this case because I've never seen a single case under 6 millimeter and turns out to be appendicitis, and this case is under 6 millimeter. So this is falling into this category, case with lymphoid hyperplasia and under 6 millimeter. Okay, another normal case measuring 5.5 millimeter, but there is thickening of lamina propria, so there is lymphoid hyperplasia. There is no hyperemia, but there is some simple fluid around the appendix in this image, but in other images, the fluid is not actually only around the appendix. The fluid is in the right lower quadrant and it's free. So free fluid, simple free fluid by itself is not a very important finding and can be seen in normal individuals or patients with lymphoid hyperplasia, as in this case. So the appendix is compressible from 5.5 to 3.0 millimeter. There is no surrounding echogenic fat. In this case, this part is a normal echogenicity, not creeping fat. So this patient is falling into the category, the first category again, lymphoid hyperplasia under 6 millimeter. Another normal appendix. Here you can see the inner layer hypoechoic. It's thickened. The measurements are over 0.8 millimeters, so there is lymphoid hyperplasia and it's filled with content. There is some free fluid, simple free fluid around it. We can see some compression, very mild compression. And here, this is the outer lumen. And the diameter is actually over 6 millimeter, measuring 6.3 millimeter. There is no increased echogenicity, and this is actually a normal case falling into this category between 6 and 8, lymphoid hyperplasia. And when the appendix is over 6 millimeter with lymphoid hyperplasia, it can easily be overcalled as appendicitis. How do we differentiate this group with this one? So it may be very difficult because the appendix is already distended. There may be some hyperemia and there may be some simple free fluid around it. We need to look for surrounding echogenic fat. That's the most important piece, or some other findings like perforation or complex free fluid. Then if you see the secondary signs associated with this, then you can call it appendicitis. Here is another example of a normal appendix, but this one is very distended, measuring up to 8.1 millimeter. It is filled with content, but if you look at it, there is no lymphoid hyperplasia. There is no thickening of the inner layer. And there are two layers. They are both very thin. There is some vascularity in the wall, but most of this is artifactual, so I wouldn't call this as hyperemia. There are no secondary signs, no echogenic fat, no fluid collection, and this one is unfortunately called as appendicitis, but this is a normal appendix falling into this category, a normal filled with content measuring over 6 millimeter. Another one called as appendicitis, here measuring up to 6.4 millimeter, so it's over 6, and there is no thickening of the lamina propria, so there is no lymphoid hyperplasia. This is compressible, so in the report it was called as partially compressible. So this is actually a normal compression. You can't compress the appendix more than this. And there is no hyperemia. There is no increased echogenic fat. So this should not be considered as creeping fat or increased echogenicity because this is diffuse. This is not more pronounced around the appendix, and this should not be overcalled. So this patient is actually falling into a normal appendix without lymphoid hyperplasia and over 6 millimeter. Another normal appendix measuring 5.9 millimeter, but there is thickening of the lamina propria. So if you measure this lamina propria, it's over 0.8 millimeter, and there is no hyperemia. This vascularity should be considered as normal, and then no fluid collection, no increased echogenicity, no appendicolite, no lymphadenopathy. So this is a normal appendix with lymphoid hyperplasia. Another normal appendix with lymphoid hyperplasia here. The appendix is measuring up to 6.8 millimeter, and the lamina propria, the inner hypoechoic layer, is 1.3 millimeter. Some vascularity, but it's not hyperemia. There is no surrounding echogenic fat, no lymphadenopathy, no fluid collections, and it's compressible. So this patient falls into the category of hyperplasia, with the appendix measuring between 6 and 8 millimeters. Here is an example of a normal appendix. Here you're seeing the initial ultrasound study and the next day ultrasound study. This is a common practice what we do. If the initial ultrasound is not conclusive, we repeat the ultrasound rather than jumping into a CT study right away. On the initial ultrasound, the appendix looked very distended, even measuring over 7 millimeters. And there were echogenic structures within the lumen of the appendix that were mobile. For example, here, mobile echogenic structures, and here, this one. This one has some posterior acoustic shadow, and these ones too, but this one didn't have. So there are some echogenic foci, but they don't look calcified. They are not echogenic enough. And the posterior acoustic shadows are not like a calcification. So these are most likely feces, some fecaloid material, but not calcified and not obstructive. We know that because they're not occupying the full lumen of the appendix and they are mobile. And in this one is actually closer to the tip. So the tip is actually less distended compared to proximal, and there is no distension of the tip, so this is most likely not obstructive. And compression is slight from 7.3 to 6.7. So this one is actually overcalled as appendicitis and turned out to be a normal appendix falling into this category, over 6 millimeters, filled with content. Here is another example of a normal appendix measuring up to 5.4 millimeters. It is located underneath the terminal ileum. The terminal ileal wall looks a little bit thickened here, a little distended here, and the appendix is right below it. There is content, there is no lymphoid hyperplasia, there is no thickening of the lamina propria, there is no fluid collection. So, and we can see the appendix nicely here. So this is actually a normal appendix under 6 millimeter filled with content. Another normal appendix, there is content but also thickening of the lamina propria, so there is lymphoid hyperplasia and there is some fluid around the tip of the appendix, enlarged lymph nodes or reactive lymph nodes, and small bowel interception. So there's lymphoid hyperplasia confirming the findings in appendix. There is gas in the lumen of the appendix, which is usually associated with a non-inflamed appendix. No hyperemia, and the appendix is compressible. So this was a completely normal appendix with lymphoid hyperplasia falling into this category, over 6 millimeter with lymphoid hyperplasia. This group of patients are usually overcalled. This one and this one are overcalled as acute appendicitis. You need to carefully look for secondary signs to differentiate. Here is a straightforward appendicitis, very distended with an appendicolite which looks obstructive, and there is no hyperemia, as you can see. Hyperemia is not a reliable finding. Even if there is advanced appendicitis, you may not see hyperemia, and even with normal cases or lymphoid hyperplasia, you may see some increased vascularity. And in this case, there is increased echogenic fat around the appendix, and the lumen is measuring 16 millimeter, very, very distended. And falling into this category, an appendicitis over 6 millimeter and filled with content. Another appendicitis with fecalite here is distended to 13 millimeter. There is no hyperemia on Doppler assessment. There is increased echogenic fat around the appendix. So this, I'm calling it increased echogenicity because it's more pronounced around the appendix and it's not uniform in the right lower quadrant. So falling into the category, same category, over 6 millimeter filled with content and with a fecalite. And this is an appendicitis with hyperemia. It is very distended, 17 millimeter. There is content within the lumen. This content could be hemorrhagic material or pus as well. The wall is thickened. The normally wall measures up to 3 millimeters, but this wall is 5 millimeters. There is no lymphoid hyperplasia in this case, and you can see the content, and there is increased echogenicity around the appendix, very obvious. And there is secondary inflammation of the terminal ileum. Here in this case, you can see wall thickening. We thought this case could be perforated because when there is significant inflammation in the right lower quadrant, there is usually perforation, but at surgery there was no perforation, and these are just secondary inflammation. So this patient is falling into the first category, appendicitis over 6 millimeter with content. Another appendicitis, this is also huge. This is the base, this is the tip of the appendix. There is a fecalite with posterior acoustic shadow with sharp lateral margins, and it looks obstructive. It's occupying the full lumen, and it's not mobile. And there is this echogenic content within the lumen, some increased vascularity, and this content could be hemorrhagic or just fecal material as well. So this is falling into the second category, an appendix, distended, filled with content over 6 millimeter and associated with a fecalite. This is actually a very interesting case. 5-year-old male with a huge appendix measuring 20 millimeter in caliber. She comes to ER with pain, but during the ER admission, the pain resolves completely. And then when the patient comes to ER, holding the hand of her mother and eating a burger. Then the ultrasound shows this clear appendicitis. We are seeing the appendix all the way from base to the tip. There is content in the lumen. There is no lymphoid hyperplasia. It's distended. So we called it appendicitis, but the surgeons didn't believe us, sent the patient home. The patient comes back the next day without any clinical findings, no pain, and she is eating very well. There is no loss of appetite. We are doing the ultrasound. Second day, calling it appendicitis again. The surgeons don't believe us. Third day, we repeat ultrasound, call this as appendicitis. Surgeons, we have a long discussion with the surgeons, and eventually they do a laparoscopy and confirm the diagnosis of acute appendicitis. But this is one of the cases that the clinical presentation and the imaging findings do not correlate. There is a huge discrepancy. And this patient is falling into this first category and the standard appendix over 6 millimeter. Another case of a straightforward appendicitis with striking features. The diameter measures 7.1 millimeter, but it's partially compressible. So compression is not reliable. There is some fluid around the appendix, as you can see here. We thought this could be a complex collection and may represent perforation, although we didn't see any disruption of the wall, but at the pathology, this was not confirmed as perforation. And the other striking feature is thickening of the appendiceal wall. So this wall is very thickened and echogenic here. The echogenicity is pronounced because there is also lymphoid hyperplasia here. There is thickening of the lamina propria, and the muscularis propria is also very pronounced. So that's why the wall looks thick and echogenic here, and there is surrounding echogenic fat. So, and there is no hyperemia. So hyperemia is not a reliable finding either. So this patient actually falls into the category of appendicitis with lymphoid hyperplasia. We called it as lymphoid hyperplasia because there is thickening of the wall measuring over 3 millimeters, and there is surrounding echogenic fat. Another case of appendicitis. So in this one, there is lymphoid hyperplasia. We can see thickening of the inner hypoechoic layer, lamina propria. Some free fluid around it and hyperemia. The wall. And the appendix is compressible. So compression is not reliable. Free fluid, it's not a reliable finding either. So, but it's appendicitis, and we saw this. There is an echogenic structure here. The posterior acoustic shadow is not very clear. We don't see the acoustic shadow in the transverse plane. In the longitudinal plane, we see it, but it doesn't appear as a ficalite. The lateral margins are not very sharp, but it doesn't look like gas either. So we called as this could be a ficalite, but at histopathology, it turns out to be not ficalite. It's just hemorrhagic fecal-like material. So these echogenicities that are not gas or ficalite could be like fecal-like material or hemorrhagic material, and they don't really cause obstruction. And in this case, there was appendicitis associated with lymphoid hyperplasia, which could be the etiologic factor. And as you can see here, it was still compressible, and there was only some simple free fluid. The surrounding echogenic fat is not seen. We don't really see it. So this is one of the very difficult cases. But look at the size. It is 7.3 millimeter. So it fell into this category. And appendicitis over 6 millimeter with lymphoid hyperplasia. This is very difficult to differentiate from these categories with lymphoid hyperplasia without appendicitis. Here is another example of an appendicitis. The appendix is very distended, measuring 10 millimeters, filled with content. It is not compressible, as you can see here, and there is simple free fluid around the appendix. There is hyperemia. This is actually not normal. It's actually this appendix falls into the category of the first one, an appendicitis over 6 millimeter with content measuring 10 millimeter. Here you can see another appendicitis measuring up to 7.8 millimeter in maximal caliber. And there is hyperemia, as you can see here, and the appendix is not compressed. It is filled with fluid and there is increased echogenicity around it, and this was confirmed appendicitis with content measuring over 6 millimeter. Here is another appendicitis with mild hyperemia. The appendix measures up to 9.9 millimeter. It is not compressible, and you can see the thickening of the lamina propria here. It's mild, but you can see it here, and there is some fecal content as well. There is hyperemia, better seen on the transverse images, and increased echogenicity around the appendix. And this is an appendicitis with lymphoid hyperplasia measuring over 6 millimeters. Another example of an appendicitis that is actually right beneath the terminal ileum. As you can see here, it looks normal proximally, but be careful, the proximal looks normal, measuring 2.7, but the distal appendix is measuring 7.1 millimeter, and there is an appendicolite in it. The appendicolite is distally located. So this was actually a segmental appendicitis, which was involving only the tip of the appendix. So we should be careful to call normal before seeing the entire course of the appendix. So this is in keeping with an appendicitis filled with content and appendicolite measuring over 6 millimeter. Here you can see another appendicitis. That's the cecum, that's the base of the appendix, and that's the tip. It is distended, measuring up to 7.2 millimeter. The wall is thickened, it's measuring over 3 millimeter obviously, and there is hyperplasia. There is thickening of the lamina propria, lymphoid hyperplasia, and there is echogenic fat around the appendix, and this echogenic fat is focal, not uniformly surrounding the appendix, but more focal here, and there is normal areas on the right side and posteriorly, and there is hyperemia. In this one it looks normal vascularity, but in this one it looks hyperemia. There is no compression of the appendix, so this is in keeping with an appendicitis measuring over 6 millimeters and with lymphoid hyperplasia. Another example of an appendicitis with distended lumen measuring up to 11 millimeter. There is mild hyperemia surrounding echogenic fat. It's filled with content, and there is this complex fluid collection adjacent to the appendix. We thought this could be the site of perforation. Also, the wall was irregular and it was not compressible. So we suggested perforation, but there was no perforation at surgery or in pathology. So this appendix fell into the category of appendicitis with content measuring over 6 millimeters. Next topic is perforated appendicitis, which is very important. This is what we are trying to avoid. This is why we are doing imaging, not to see the perforation. Here is an example of a perforation from the base, and you can see the pus and collections, abscess. So an appendectomy comes with morbidity and mortality, either laparoscopically or open. If there is perforation, there is 3.5-fold increased morbidity and 6.5-fold increased morbidity. So we don't want this, and we are doing the imaging to diagnose the appendicitis early before it perforates. After perforation, the diagnosis is more difficult. The appendix is harder to find because it's not distended anymore. There is collection, there is extensive inflammation, peritonitis. We can see complex fluid collections. Sometimes they mimic a pseudomass. Usually, when the appendix is perforated, secondary signs are more helpful and the diagnosis will be harder. Here is an example of another perforated appendicitis, which I borrowed from Dr. Çiğdem Ulukaya Durakpaşa. In laparoscopy, you can see the cecum, the appendix, and perforation at the base and the fecalith. And the fecalith can be seen on the X-ray, but we were not able to find the appendicitis on the ultrasound. If the perforation is in the early stages, we can still detect the site of perforation. As in this case, the appendix is inflamed, the wall is thickened, it's filled with content, and this is the tip of the appendix, and there is this disruption of the wall, it's focal disruption of the wall associated with this complex fluid collection that is representing the site of the collection. And there is no hyperemia, as you can see here. And this image is very demonstrative. That's the thickened ileum, secondary inflammation of the ileum. Appendix is still distended, and there is this complex fluid collection. Another example of a perforated appendicitis. On dynamic images, you can see the appendix lumen and the collection and the communication between them. So this is a complex collection, most likely pus. It is hyperechoic and it's showing a slow motion, and you can actually detect the mobility by pushing your probe onto it. And here is the appendix. It can be slightly compressed and the wall is thickened. There is increased echogenicity around the appendix and significant hyperemia. When there is perforation, there is usually very severe peritoneal inflammation. The omentum may be surrounding the appendix, and the inflammatory findings are very severe, as in this case. So even if you don't see the defect in the wall, if you see significant inflammation, you should suggest perforation. Here is another example of a perforated appendicitis. This was actually very difficult to diagnose, but here is the cecum. Here is the appendix. The perforation was at the base of the appendix. And the distal part of the appendix looks normal. And here is the distal part, here is the proximal part. So, and the collection is seen as hyperechoic area, and it was difficult to detect this collection. And this is the distal appendix, which appears normal, and distal appendix normal, but proximally that's the fluid collection. And there is discontinuity of the appendix from cecum, as you can see here. So cecum, and we lose the appendix, then we start seeing the distal appendix. But this is the site of the disruption, and it was confirmed at surgery. Completely disrupted appendix. Another perforated appendicitis filled with gas. So gas is usually associated with a normal appendix because it excludes obstruction. But when there is appendicitis and in the advanced stage, we can see gas due to necrotizing pathology. And here, in this case, there was extensive gas in the appendix, but this was a perforated appendicitis with surrounding echogenicity, and here you can see the surrounding echogenicity better and mild hyperemia. Another important thing about appendicitis is they can present with bowel obstruction. If you cannot find other causes of bowel obstruction in a child, you should consider it as perforated appendicitis unless proven otherwise. In this case, there was bowel obstruction, we couldn't see much, and here we did the ultrasound. Because of the gas, it was not diagnostic. We could see the proximal appendix, that's normal. Distally, we don't see it. The other important thing is to see the entire appendix. In this case, we couldn't. But we did a CT afterwards. This contrast is because of CT. But before CT, we saw this appendicolite on the X-ray. So the appendicolite may not be very radiopaque, as in this case. It can be very subtle. So the CT confirmed this appendicolite and a huge appendix, which was inflamed. So the proximal appendix was normal. It was just a short segment of the appendix. This appendix is almost 20 centimeter going all the way anteriorly to the pelvis, crossing the midline. It was huge. And it was treated with antibiotics, and after 1 week of treatment with antibiotics, we were able to identify the appendix on the ultrasound. It was still distended, it's still inflamed, and there was significant echogenicity around it. Then after the follow-up, the patient had the surgery and the appendix was resected. When perforation occurs, there is usually significant inflammation in the right lower quadrant. We can see it as increased echogenicity, creeping fat, complex fluid collections, as you can see here. And the omentum may appear as an echogenic structure trying to restrain the abscess or site of perforation. In this case, there is perforation. We can see this abscess. We cannot see the appendix itself. This is just the terminal ileum, which is thickened, significant inflammation, and some vascularity in it and free fluid in the pelvis. This is called plastron appendicitis. It is actually the abscess formation that occurs after perforation and surrounded by the omentum. So it is under control now. Usually the surgeons don't prefer to do immediate surgery when there is plastron appendicitis. They usually treat with antibiotics and wait until the inflammation resolves. In this case, there was inflammation, this pseudomass, this plastron. Then after 3 days, there was improvement of this inflammation and inflamed omental appearance. And then we started seeing the appendix. It was actually some parts of the appendix was returned to normal size, and then the surgeons then performed the appendectomy 12 weeks after this. Another case of perforated appendicitis. This is the ultrasound at the initial presentation. There is a complex collection with vascularity, but this is in the pelvis, not right lower quadrant. And this is the ovary, so it is not possible to differentiate this from the ovary. So this patient comes during my call, and the resident sees the patient, and resident thinks that this could be ovarian torsion because the ovary is large, there is still some flow, and there is increased flow, but the resident thinks that this could be torsion, and during the torsion phase there is reactional compensatory flow in the ovary. That's why it looks hyperemic, hypervascular. And for comparison, this is the left ovary. This is the right ovary with abscess. So reactional hyperemia, hypervascularity doesn't happen in ovarian torsion. No such thing happens, but this was actually just the abscess because the appendix was extending to the ovary, and after the perforation, the abscess was around the ovary. This was actually a paraovarian abscess, mimicking an ovarian pathology. Another finding of acute appendicitis is increased periportal echoes, also called periportal coughing. It is a subjective finding and may not be seen in all cases, but sometimes we see it and it can be helpful. Here, as you can see, there is increased echogenicity around the portal veins diffuse in the liver. Another example for correlation. So this is abnormal periportal coughing and this is a normal for comparison. How can it help? In this one, the patient presented with signs, symptoms of appendicitis, and the appendix could not be seen on ultrasound, but we could see this periportal coughing. So this is a non-specific finding, but may be associated with intra-abdominal pathologies. Any infection or inflammation in the abdomen may cause this. IBD, gastroenteritis, bacterial gastroenteritis, viral gastroenteritis may be associated. But in this case, we called it and we said, this could be a sign of appendicitis. Please do a CT. And the CT actually confirmed the appendicitis. The appendix is extending to the mid-abdomen, coursing in the cranial direction. And on the axial, on the sagittal, the wall was thickened, so it confirmed appendicitis. And periportal coughing is an ultrasound finding, and you cannot see anything on CT, or if you do an MRI, you won't be seeing anything. Radiography is not routinely recommended, and presence of fecalith is rare. Even if you see it on the ultrasound, you may not be able to see it on radiographs. But in this case, it was helpful. It showed the appendicolite. In this case, it's not well seen on the X-ray, but can be seen better on the CT study. And this was an appendicitis with an appendicolite. How does appendix or appendicitis look on CT? CT is the next step if ultrasound is inconclusive or there are complications. Here is a normal appendix, the tip, the base, and this is how it appears on the CT. The measurements of the caliber is usually a little bit higher on CT, and here we see a gas-filled appendix, and there is no fat stranding around it, just tiny streaky densities that's within normal limits, but there is no abscess, no enlarged lymph nodes, no fluid collection. So this is just a normal appendix. The lumen is under, the maximal diameter is under 7 millimeter. Another normal appendix seen on the CT. So the appendix, the origin of the appendix is always retrocecal, posterolateral, and many times the most parts of the appendix is retrocecal, so hard to find on ultrasound, but on CT it cannot hide and we can see it, and that's the retrocecal appendix, which is normal. As you can see, there is minimal stranding around it, and this should not be overcalled as appendicitis. The caliber of the appendix is still normal, up to 6 or 7 millimeter, and that's the normal appendix. Here you see a normal appendix with ultrasound and CT correlation. On the ultrasound, there is gas in the lumen of the appendix, which was better seen on the CT images. It has normal caliber, and presence of gas usually excludes appendicitis because the air can pass easily from cecum to appendix and excludes an obstruction. As you can see here, there is not much fat. This is usually the case in children, not like adults. There is not much visceral fat. Fat is our friend in CT. It helps us as a contrast, creates a contrast between the other structures, and when there is inflammation, we can easily detect it. But in children, it may be extremely difficult to identify the appendix, especially when it's normal. It may not be differentiated among other normal looking bowel loops. Here is another challenging case with an opacity in the right upper abdomen. There is an opacity. We thought this could be a gallstone because it's adjacent to the liver, and that's how it appears on CT. However, CT confirms that this was an appendicolite, not obstructive, because there is no inflammation. Appendix has normal size. There is some gas in the appendix, and the surrounding fat is clear. And here you can see the cecum is in high position, and even the appendix extends in the cranial direction and abuts the liver, but there was no inflammation. Another example of a normal appendix on CT. The caliber is usually under 6-7 millimeter. Here the surrounding fat is clear. This should not be overcalled as acute appendicitis. So how does appendicitis look? Here is an appendicitis. There is distension of the appendix, usually 6-7 or higher. There is fat stranding around it, and the diagnosis is clear in this case. Another appendicitis, in the right lower quadrant we see this inflamed appendix, the wall is thickened, there is surrounding fat stranding. This is appendicitis. Another example of appendicitis, here extending in the craniocaudal direction, and there is fat stranding and thickening of the lateral conal fascia here. Some, maybe a little bit fluid, fat stranding, and thickening of the fascia. Another example of appendicitis. Here is the thickened appendix and fat stranding around it. This is a clear appendicitis. Another example of appendicitis but with perforation. Here is the fecalith still within the lumen, and here is the appendix distended, filled with fluid, and here is the site of perforation, and this is the abscess formation, and this abscess formation is actually more extensive into the pelvis, and this is a perforated appendicitis, and because of peritonitis we are seeing this bowel obstruction as well, and ultrasound is very helpful for the management of these collections percutaneously, because usually the interventional radiologists want to see if this is drainable or not, and CT is the best for this, because on the ultrasound you may not see if there is a bowel loop or colon intervening this collection or not, but CT can easily show this. This is a very young child, 2-year-old, with perforated appendicitis. As you can see here, there is on the X-ray, there is an appendicolite in the right hemipelvis. This was confirmed on CT, but there is also a second fecalith here, which we cannot see on the X-ray. And after the CT, we saw that these appendicolits were actually floating within the abscess collections. So there are two communicating abscess collections in the lower abdomen and pelvis secondary to perforated appendicitis. Here is another perforated appendicitis presenting with bowel obstruction. So you can see multiple loops of bowel and air fluid levels, and CT confirms appendicitis with an appendicolit in it. Appendix is distended, there is wall thickening, there is surrounding echogenic fat and surrounding fat stranding on the CT, and this complex fluid collection. And this is a perforated. Here is another challenging case with perforated appendicitis. We did the ultrasound. We saw significant inflammation in the right lower quadrant with a thickened terminal ileum, echogenic fat, some free fluid here, complex collection here, and you can see the inflamed terminal ileum. We are not sure what is going on, and in this case, the CT showed the inflamed appendix. This is the proximal appendix measuring up to 11 millimeter, the terminal ileum with secondary inflammation, significant fat stranding around it. This turns out to be a perforated appendicitis. Here I would like to share you some numbers regarding the performance of ultrasound and CT. When the appendix is visualized, the accuracy of ultrasound is comparable to CT. In this study, they reviewed multiple centers for the performance of ultrasound, and they found these numbers. So when the appendix is not visualized, the sensitivity of ultrasound for the diagnosis is 73% and the specificity is 97%. When the appendix is visualized, the sensitivity goes up to 98% and the specificity is 92%. Ultrasound is a reliable tool when the appendix is visualized, but the appendix cannot be visualized all the time. The visualization rates ranges between 22 to 98% depending on the experience of the sonographer or the radiologist. Acute appendicitis cannot be excluded if the appendix is not visualized. So what happens if the appendix is not visualized? In centers with pediatric radiology experience, it is still a reliable tool. The sensitivity of ultrasound ranges between 74 to 100% and the specificity ranges between 88 to 99%. Our tools for the diagnosis of appendicitis is not limited to CT and ultrasound, but we also use MRI. But we should remember that these studies are not competitive modalities, but complementary to each other. When there are studies comparing the use of ultrasound and CT versus ultrasound and MRI, and it was found to be comparable regarding the duration and accuracy. And also another study compared the use of ultrasound versus MRI, and they were again comparable. MRI is very helpful for the diagnosis of appendicitis. The main issue is logistics. There is no radiation, it's fast, and it's diagnostic, as you can easily see the appendix, as in this case, that's the cecum, that's the appendix, and you can exclude other findings, that's the ileocecal junction. If you're doing MREs, you will realize that you can see the appendix all the time. Here is a sample MRI protocol for the diagnosis of appendicitis that I was using in Istanbul. We were doing triplane single-shot T2s. They are very fast. It gives you an idea, anatomy, and the axial single-shot T2 FATSAT images, and also an axial turbospin echo T2 FATSAT. And you can see the difference between the resolution and image quality. This one's much better, but takes longer. And also diffusion, DWI and ADC map images. We did not use contrast injection, but contrast can be injected and you can see the inflammation better with the contrast injection. Here is an example of appendicitis. The appendix is distended, filled with fluid. There is T2 signal intensity around the appendix. Here on the post-contrast images, there is enhancement of the wall and the periappendiceal soft tissues. And here you can see the enhancement and the T2 signal intensity. There is fluid signal around the appendix, and the appendix lumen also appears hyperintense. So this is confirming the diagnosis. Also, diffusion-weighted MRI is very reliable for both diagnosing inflammation in the appendix and for abscess collections. And the diagnostic accuracy reaches up to 100%. Here is an example of appendicitis. This is an inflamed appendix, and you can see the increased signal intensity, the DWI. There was also a small pocket of abscess in this case. Another example of perforated appendicitis demonstrated by MRI. Here is the T2 weighted images, and that's the cecum, that's the appendix, and inflamed, distended, thickened wall associated with a complex collection, which is the abscess. We didn't inject contrast, and we can see the abscess on T1 weighted images, but diffusion weighted imaging nails it. It clearly shows the abscess and inflammation in the appendix, and you can also color code it and show it red in color. Here is another example of MRI. MRI can be helpful to show the abscess formation in the liver. This patient actually presented with appendicitis, perforated, and underwent surgery, and 1 week after surgery comes back again with fever, and we are doing the ultrasound. We saw something, we are not sure, there is a lesion in the liver, but it was atypical. So here is the MRI. On the MRI, we can see some inflammation in the right lower quadrant at the site of the perforated appendicitis, and there is a connection, there's an extension into the liver, and within the liver, corresponding to segment 6 of the liver, there is this peripherally enhancing lesion and showing restricted diffusion in the center. So this was a liver abscess secondary to appendicitis, and the dark lesion in the center of the lesion turns out to be a fecalite. And this was drained later on. Another example, which I borrowed from my friend Dr. Öztürk, he actually showed the fecalite by ultrasound and CT. Here is the patients presenting with perforated appendicitis. They are doing this ultrasound and CT, and there's an abscess in the liver, and there is the fecalite in it. So the fecalite can migrate into the liver along with the abscess. So these are examples. And what is the differential of acute appendicitis? So clinically, everything can be in the differential, but by imaging, the most commons are usually, I will go through them. One of the most common ones is viral enteritis. And in this case, there is usually thickening of the terminal ileum, and the appendix is normal. We can see it beneath the inflamed terminal ileum. So that's one differential. The second one is Crohn's disease. Crohn's is may be associated with inflammation of the appendix. When it's involved, it may be very difficult to differentiate by imaging, but clinically it's usually easy to differentiate because Crohn's patients usually present with a long history of diarrhea and symptoms. Appendicitis is obviously an acute pathology, but the findings may be similar. There is inflammation in the right lower quadrant, thickening of the wall, but also the cecum. We can have reactional inflammation in the terminal ileum and cecum that I showed you before, but in cases with Crohn's disease, the inflammation is usually more severe in the cecum than appendix. Another example of Crohn's disease, the inflammation in the cecum and ascending colon is very severe. This cannot be a reactional inflammation secondary to appendicitis, but the appendix was also involved and thickened, and on the CT we can see the thickening of the wall and inflamed appendix along with the cecum. Tuberculosis can involve the terminal ileum and appendix as well. In this case that I borrowed from Dr. Natalia Debichinsky from Ukraine, there is extensive inflammation of the distal ileum, terminal ileum, fluid collection, and the appendix is markedly thickened. So this much inflammation cannot be secondary inflammation to appendicitis. So it's obviously a secondary inflammation. Another differential is epiploic appendicitis. This is a common pathology in adults, but in children it's so rare, so we should be familiar with that. It is inflammation or infarction of the appendages of the colon. The location is typical of most commonly the ascending colon, the anterior aspect, but it can be on the other sides of the colon as well. And there is fat stranding anterior to the colon, anterior to the ascending colon. The appendix is normal, not as expected, and we can see this central dot sign, which is this enhancing rim with a central dot. This dot is most likely caused by a thrombosed vein. So this is called epiploic appendicitis. It is a reversible pathology. No need to do surgery, and surgery should be avoided. Meckel's diverticulitis can mimic appendicitis both clinically and by imaging. Because it's so rare and most of the time the diagnosis is made with nuclear medicine and at surgery, we don't, as radiologists, we are not very familiar with the appearances of an inflamed Meckel's, but it's a bowel structure similar to appendix. It is shorter than the appendix, but broader than the appendix. So it is like a short and fat appendix. But when it's inflamed, it shows the similar findings. The wall is thickened, there is fluid distension in the lumen, and there may be hyperemia, but in this case there was not on the CT, and the most common location is right lower quadrant. And there may be surrounding fat stranding. In this case, we are seeing it as an oval-shaped structure. This is too big for an appendicitis. And on the sagittal, you can see this. This is an inflamed Meckel's diverticulum. Another case of Meckel's diverticulitis as confirmed on nuclear medicine study here is the Meckel's, and the appendix is normal, by the way, but there is this inflamed bowel structure. It has a polygonal configuration, not like an elongated appendix. Not hyperemic, but there is this fluid retention in it and an inflammation around it. The diagnosis can be very challenging in these cases, especially if you're not seeing the appendix. This patient is also confirmed as Meckel's diverticulitis, and here there's a fluid-filled structure. It is too big for an appendix, the standard appendix, but there was hyperemia, there was surrounding inflammation, and the appendix was not seen. So this turns out to be Meckel's diverticulitis. So, and there is this gut signature around it. So when there is this layered appearance, we know that it's a bowel structure. However, when you see a gut signature, you should also consider enteric duplication cyst. Here is the initial ultrasound study in a 7-year-old presenting with sharp pain in the right lower quadrant lasting for 1 day. So this fluid-filled structure, too big for an appendix, but there is inflammation around it. There is hyperemia, there is echogenic fat, and the repeat ultrasound next day shows the same lesion but smaller. So even Meckel's diverticulitis and infected duplication cyst show fluctuation in configuration and size. And this patient, I thought this was going to be a Meckel's diverticulitis, but turns out to be an enteric duplication cyst, which was infected. Another differential could be infected urachal remnant. Infected urachal remnants may present with a complex inflammatory mass or an abscess that may mimic a plastron appendicitis. There is this hyperemia, this complex fluid collection, and we did the CT. On the CT, we confirmed the presence of abscess. We are not able to see the appendix nicely, so this can easily be misdiagnosed as perforated appendicitis, but the location is very helpful. It is just superior to the bladder in the midline because it's a urachal remnant. And another diagnosis is mucocele. We rarely see it in children, especially in children with cystic fibrosis, and they usually do not present with clinical signs of appendicitis, but in 25% of the cases they may present with right lower quadrant pain and may be easily overcalled as appendicitis. In this case, this is a CT with contrast injection. There is no contrast enhancement in the wall, but the appendix is very distended, and there is calcification in the wall of the appendix, and the surrounding fat is very clear, no signs of appendicitis, and turns out to be a mucocele of the appendix. Tumors can be seen, carcinoid tumors, even in children, and we cannot really diagnose them. They are usually diagnosed at surgery and after the pathology. Here we just see a distended appendix, and this is measuring 11 millimeter and some hyperemia, and on the CT study the appendix is distended. There is some fat trending around it. We called it as appendicitis, and it's after the resection pathology reported as appendiceal carcinoid tumor and staged it. Another example, here we called it as acute appendicitis with fat stranding, distended appendix. It's very straightforward. We are very confident, and it turns out to be another appendiceal carcinoid tumor, and here how it appears during the laparoscopy. It's very distended, not much inflammation, but turns out to be an appendicitis and carcinoid tumor. Most of the time, they are just incidental findings. In conclusion, Acute appendicitis represents most common cause of abdominal pain and surgical emergency in children after 2 years of age. Ultrasound remains a central tool. However, surgeons do not operate on ultrasound images, they operate on patients. Lymphoid hyperplasia alone should not be overcalled as appendicitis. Ultrasound and CT are not competitive modalities, but complementary. Also complementary to clinical evaluation, including history, physical examination, and laboratory test results. Thank you very much for listening.